This is the grand finale for Robbins Chapter 13, focusing on LCH, the spleen and the thymus. This is Masterclass Concept 6, so let's dive right in. Let's start with our clinical case, the pediatric presentation. Our patient is a 3-year-old boy whose chief complaints include a soft swelling mass on the scalp. He also presents with exophthalmos, meaning bulging eyes, and constant thirst with dilute urine, which points to diabetes insipidus. You might ask, punched out lytic bone lesions in a 3-year-old? Remember, multiple myeloma is for the elderly? This classic triad is the hallmark of Hand-Schüller-Christian disease, which is a form of Langerhans Cell Histiocytosis. Let's look at unmasking Langerhans Cell Histiocytosis, or LCH. In phase 1, we see the normal border patrol, demonstrating a horizontal integration of dermatology and immunology. These normal cells catch invading antigens and present them to T cells. In phase 2, we have a rogue invasion. This is driven by the BRAF V600E mutation, which is notably shared with melanoma. These mutated cells multiply out of control, invade bones, skin, and internal organs, making them neoplastic. Ultimately, LCH is driven by mutated dendritic antigen-presenting cells that originate in the epidermis. Moving on to diagnosing LCH, we have the 3 legendary clues on our pathology specimen card. First is morphology under light microscopy. You will see abundant pink cytoplasm with folded groove nuclei that precisely mimic coffee beans. Second is the immunophenotype, or the ID tags. There is a strong expression of S100, CD1A, and Langerhans, also known as CD207. A helpful memory hook is skin cells like Langerhans equals S100, CD1, and Langerhans. Third is electron microscopy, where we find Burbeck granules. These are rod-like tubular structures with a zipper stalk and dilated end that look exactly like a tennis racket. Next is the LCH clinical cheat sheet. For infants under 2 years old, the disease is Letterer-Sibe, which is a multi-system condition. The clinical picture includes a fatal skin rash that resembles severe seborrheic dermatitis, massive hepatosplenomegaly, and bone marrow failure. The prognosis here is aggressive and fatal without intense chemo. For young children aged 2 to 5 years, it is Hand-Schüller-Christian, a multifocal disease. This features the classic triad skull defects, diabetes insipidus from pituitary compression, and exophthalmos where the eyes are pushed outward. The prognosis is variable but treatable with chemo. Finally, for older children and teens, we have eosinophilic granuloma, which is a unisystem disease. This presents as a single benign lytic bone lesion, usually in the ribs or femur, and the tumor is packed with reactive normal eosinophils. The prognosis is excellent, as it heals spontaneously or via local excision. Now we travel to destination 2, the left upper quadrant, the spleen. The spleen is truly a masterpiece of engineering. It is often ignored until you feel a massive one on palpation, but make no mistake, the spleen is the ultimate filter. Looking at its internal architecture, we divide it into 2 main zones. The white pulp is the immune zone, containing B cell follicles and T cells located in the periarteriolar lymphoid sheath or pulse. Its primary function is to produce antibodies. Then we have the red pulp, which acts as the blood filter. This area contains the cords of Billroth and hungry macrophages lining the sinusoids. Their function is to eat old, defective, and antibody-coated RBCs and platelets. This brings us to the clinical perils, hypersplenism and rupture. For hypersplenism, integrating with surgery, it begins with liver cirrhosis. This causes portal hypertension, leading to blood backing up into the splenic vein. The result is congestive splenomegaly, where red pulp macrophages become hyperactive, eating healthy RBCs, WBCs, and platelets. This creates profound pancytopenia, and we treat it with a splenectomy. The other peril is splenic rupture, which is a major exam favorite. Picture a teenager with EBV, meaning infectious mononucleosis. The virus causes paracortical hyperplasia, resulting in a massively engorged, fragile spleen. Dr. P's golden rule here is absolutely no contact sports for at least 4 weeks. A single tackle causes spontaneous rupture and fatal internal bleeding in minutes. Our final stop is Destination 3, the anterior mediastinum. Welcome to the elite administrative academy for T cells, the Thymus. The Thymus is home to rigorous immune education. The journey starts in the hometown, the bone marrow, where immature T cells pack their bags and leave. They arrive at the academy, the Thymus. Here they learn to recognize foreign antigens and ignore self-antigens. To reach graduation and enter the bloodstream, they must pass rigorous exams known as positive and negative selection. If a cell cannot recognize antigens or aggressively attacks the body's own tissues, it undergoes forced apoptosis and does not graduate. Let's review thymic pathologies and clinical links. Agenesis, such as DiGeorge syndrome, stems from embryology and genetics with a 22q11 microdeletion. The third and fourth pharyngeal pouches fail to develop. The result is no thymus, leading to severe viral and fungal infections, and no parathyroid glands, leading to severe hypocalcemia and tetany. Thymic hyperplasia is a mechanism of autoimmunity where rogue B cell follicles form inside the T cell academy. These B cells produce autoantibodies against acetylcholine receptors, heavily associating the condition with myasthenia gravis. Finally, thymoma is a neurological link caused by a tumor of thymic epithelial cells, the administrative staff, not the students, which present as massive anterior mediastinal masses. Up to 30% of these patients present with myasthenia gravis, experiencing weakness and drooping eyelids. You must always CT the chest of a new myasthenia gravis patient. Let's close with the molecular blueprint, showing that Robbins Chapter 13 is mastered. Remember that translocation T922 points to CML. Translocation T1517 leads to APML, the miracle cure. Translocation T814 creates Burkitt lymphoma, known for its starry sky appearance. Burbeck granules indicate Langerhans cells. The 4 CRAP criteria, which stands for calcium elevation, renal insufficiency, anemia, and bone lesions, define multiple myeloma. Pathology is not just a list of dead diseases to memorize. It is the molecular blueprint of human suffering and the roadmap to curing it. You have conquered pathology. Every translocation you memorize today is a future patient you might save. Keep revising, keep trusting the process, and never let a massive Robbins chapter intimidate you again. Hit the like button, subscribe to Conquer Pathology, and share with your batchmates. I will see you in the next chapter. This is Dr. P signing off.